alone and by yourself. And it is saying, rather than desiring more responsibility, the workers will refrain from doing that responsibility because you are controlling them. Therefore, today you are here, we are going to learn from the speakers. They're going to teach us more and guide us with how to manage and how we go about being authorities. And this book is also saying, I'm your servant. You have the right to dismiss me when you please. What you have no right to do is to ask me to bear responsibility without the power of action. That means today you're going to be motivated, going to be advised, going to be taught to do everything as the way you have to do it as managers and leaders. Once responsibility and authority have been given to people, they become empowered to make things happen. But we also have to be We thank you, Lord, that you have been with us in this moment. We ask also to be with us at the rest of the day. We ask for this and not forcing you. In the name of Jesus, we pray. Amen.
Thank you very much. We are now feeling that we have come to the right place. We have asked for the Almighty to be with us. In terms of our program for today, colleagues, we want to rush straight to the business of the day, which is about impacting, engaging, as well as sharing some experience for us when it comes to issues that are in the place of the human rights for health. But before I proceed, I do know that sometimes abantu bayakwazi ukukhala emngcwabeni orongo. So I must just confirm and announce that we are here for the Global HRH Symposium. So that if maybe, just maybe by chance you were following people and you're not sure, you can stay though because you'll still learn a lot. But if you feel that you are going to miss out on where you were supposed to go, you'll just find a way to just sneak out and go to the right venue. So here we are gathered today just as invited, hosted by WSU, Walter Sisulu University, especially the health faculty, for what has been termed the Global Center for Human Resources for Health Intelligence Symposium. And would like to welcome everybody who is here. But of course, amongst others, we would like to also acknowledge as well as programs. In the midst, we do have and we acknowledge the presence of the National Department of Health, as led by the DDG responsible for hospitals, human resources for health and infrastructure. We also acknowledge ECDOH, Eastern Cape Department of Health, that is also represented by a general manager responsible for, he usually says, I'm responsible for legislative work. Just give me legislative work, planning and M&E, Professor Moko. We are also having and acknowledging that there is a representation from the College of Medicine in South Africa, as well as Nelson Mandela University, our medical school, as represented by Professor Modley. The South African Medical Association has also made an effort to be part of this session, as represented by Dr. Sillo. I would like to also acknowledge sincerely, and I know especially whenever I come to this side of the Eastern Cape, we know the value add, the relationship and the role that is played by the House of Traditional Leaders. So we do acknowledge that we also have a stakeholder in the form of House of Traditional Leaders. But of course, in the health space, we don't work alone. We also have social partners that we have also extended an invitation to come through, and we would acknowledge as much as they are still to be coming and notifying us, but we do acknowledge that we have invited and do have some members in the attendance. And of course, we also acknowledge that we are in the midst of academics, and we do appreciate that in your busy schedule of writing, reviewing, and rejecting some papers, you just decided to come and be part of us and grace this occasion. We would be chucked out of this place if we do not acknowledge the presence of the Office of the CEO of Nelson Mandela Academic Hospital. If we don't acknowledge him. So we also acknowledge his presence. And of course, the speakers, as they are lined up, we do acknowledge their attendance and appreciate that they've made time. I was just trying to ensure that all of us, we feel that we are part of this session, and we do acknowledge that we are in the right place, and ensuring that we would be free to participate, to listen, and to engage as we are about to start with the program of the day.
We can't miss acknowledging Dr. Bayeni, who's the program director for the day.
Oh, yeah. I'll just stop the program and go home.
We can't miss that. Secondly, we can't miss acknowledge that there are people online who have joined with us online. For example, we have Dr. Professor Rohana Joshi, and also we have Dr. Blake Angel, and we also have Ms. Kitty Mike, who are online, have joined online with us, and other guests online at large. Thank you.
Thank you very much. And I hope every one of us now feels very welcome and is ready to participate and engage in terms of the program flow for the day. But of course, ours is just to request and call upon speakers to come to the floor, and they have been given a task to do. And as a result, we will just move straight now and have the purpose of the day, which is linked to the opening address that will be rendered by Dr. El Sobwekwe. And we would like you to come to the fore and render that item for us. Can we please give a round of applause, please? Special something. Yeah. Bitoman bonge kandi libela mazwi. So anifuna ubonga ngesingisi.
WSU abantu bahleli phansi. Kunzima kubotshwa nezibhityileyo. Yiloo nto nam nibona ndiphambi kwenu. Ndiyinkosazana yamajwarha. Oyarho Khathitho Mnango. Ovumisa. Isala kulandelwa usijekula umsitho. Dolo limnyama kuthandaza. Umuntu omhle noba sephethe izikhali. Ungabona usulimala niyazibonela nani. Ndithi xa nditshoyo ke ndiphahliwe. Ndizawuthetha ngoba ndingumuntu ophahliweyo. Kaloku mna ndingumabunjwe bhidlika njengodaka. Into eyabunjwa ngosikhuza abahluleke besithi ethos melish. Badlula lathi gulukuqunda ngena ku-medical ethics. Ndiyabhotisa xa nditshoyo andifuni kabathembu ze banomona ngoba kaloku lo ngumhlaba wabathembu. Xa ndilapha funeke ndi-acknowledge ndiyabazi oomadlomo zinto ezinomona, ndiyabazi ooyeyeye ovela bambhentsele bazawukhalaza bandigxothe endaweni yabo. Xa nditshoyo ke uba bendiyindoda ngendikhahlela kodwa ke yinto yamanyenza leyo. Sendoshiya ke ndithi ke mna ke kuni ke bathembukazi ze nitsho nithi oobhuti bethu babulisile ngoba kaloku lo ngumhlaba weenkosi esikolo sime kuwo. Sazisa ke iinkosi ezidlulileyo ezikhoyo eziphetheyo kanti siyasazisa nezizayo ngoba kaloku uba siyenzi loo nto azinoba nandawo emhlabeni woyise. Ndithi xa nditshoyo ke ndiyabhotisa. Ladies and gentlemen, our esteemed guests, our distinguished speakers, I won't mention you one by one because you've already been acknowledged. This is my way of saying to you good morning. I would like to start it by saying they've said this is for health intelligence. And I think the best way to start the day is in the mighty words of Abraham Lincoln. That is meant for health professionals like yourselves. This motivation underscores the importance of shaping the future of health through perseverance and a collective effort. In his direct words, he says, the best way to predict the future is to create it. That is why we are here. It is both an honor and genuine pleasure to welcome all of you to this international symposium that is hosted by Walter Sisulu University in the Eastern Cape of the Republic of South Africa. Hence, we are so wide and we have guests online on Teams, YouTube and Facebook. Niyasibona Moses phambili. We will discuss human resources for health intelligence. This is where our collective minds will make a difference. I'm thrilled to see such a remarkable gathering. It's full of experts, it's full of thinkers, and it's packed with professionals who are as passionate about healthcare as I am. Though I'm suspicious some of you came for the good lunch that we normally offer, and also escaping the meetings that were scheduled by their bosses. Either way, I'm glad that you are here. As we kick off this symposium, I'd like to remind you that we are about to embark on deep conversations. Yes, it's about health, workforce, it's about our resource limitations and the strategies that are going to guide us as South Africans in the healthcare system and for our future. And I must say, there's no better time than now to address these topics, especially given the high demand that is required for change. And I'm not just talking about the growing pressure that is brought about by the National Health Insurance to finally get off the ground. Nisibona nje simatasa-tasa, siphithizeliswa yithuvane yale emampondweni. Uthiwa yasuka kuba yayidinwe kuchitha-chitha apho ihlala khona, yayeka ngokuba nguchitha yazoba ngumakhi kweli cala lamampondo, izizamela. Kodwa akakho nto sinyamezele ngokuthi usaqala ukwakhenye aqalise enye asithubi kwanto kodwa siqala yonke into. Kodwa ke loo nto ayinamsebenzi ngoba uAlbert Einstein reminded us powerfully that even in the most challenging of times, there are opportunities for growth. This is where today's symposium comes in. As we've gathered the experts that you've heard from across the globe, we've got health economists, we've got national directors of health, we've got leaders in human resource for health. They are going to share their insights and yes, the strategies that we need for tackling the big questions. We're here to explore how we can strengthen our health workforce in the face of all the challenges that we have mentioned. And whilst we're juggling with the limited resources, we will find effective ways to implement our NHI without causing a nationwide meltdown. because we are experts after all, and we are professionals. Well, as I've indicated, we will be talking about workforce planning, recruitment, training, retention, career development, migration, skills mix, to mention but a few. And all these topics will require your undivided attention. I hope that you will focus, even though some of you will have rambling tummies by the time we reach 12, but please be patient. Our focus areas will be the challenges that we have with the health workforce. We'll take a closer look at these challenges, the shortages. I'm talking about burnout. Let's not forget the temptation of looking for a fatter paycheck abroad. Yes, it is welcome, but at what cost when you look at our healthcare? We've got resource limitations. It's no secret that our resources are limited in South Africa, but it's not peculiar to us. It's all over the globe. You find waiting lists everywhere. And yes, we have to figure out how to stretch our budget, like the magician when they pull out their rabbit out of the box. We'll also look at the thinkers that we have here for strategies for the South African workforce. And here, it is where the rubber will meet the road. As we discuss the future of the South African health workforce, we'll dig into practical skills, we'll dig into sustainable strategies, and we'll find ways to strengthen the system of our country. It's time to get serious, but also we must be a little creative, because when it comes to solving big problems, sometimes it helps to think outside the box, especially doctors who are always in the box. So as we go through today's sessions, I will encourage all of you, please do participate, ask the tough questions, and maybe share a joke or two. Asikho serious ngaleyo ndlela. It's going to be a long, challenging road that's ahead of us, and therefore it's still the best thing that we laugh here and then. After all, it's not only medicine that gets us well. Together we have the opportunity today to shape the future where healthcare is not only accessible, but effective, sustainable, and yes, possible, even a little bit enjoyable for those who are dedicating their lives to it. I'm thankful for you for being here again, and I look forward to the incredible conversations that we are going to have. Ayisanqabanga ke madoda nalapha kusemampondweni. Apha ke emampondweni asithuli nje siziyeke iinklasinyana zizihlalele. Senisijonge ke bethuna kangesilale besithunga. Abanye bethu bambejembeje. Ke ichuvana ezikhoyo zezisincede zibonga ithuba zizibike. Kaloku sisenabo apha ekhaya ontombi ekhaya. Ohlalelephi nohleziphi kanti nontombi futhi nabo basanyekile nobuyisiwe nobuyiswa nabo bayafuna kaloku ukuthethiswa. Kodwa ke sesincede ke bantakwethu ningezingenkani njengalachuvane kaMaliya le yafika yadelela lamjendevu wasemsamaliyeni. Zeni bacenge noko nithethe kakuhle nabo. Kaloku nethu umuntu umkwece elapha ecaleni kwakho ubuza impilo nendlebe zitsho zibe nomdla nodlamko womamela. In the words of our icon, Nelson Mandela, let me remind you that we are a people of resilience. And yes, we bounce back from adversity, something every healthcare professional embodies on a daily basis. He says, the greatest glory in living lies not only in never failing, but in rising every time we fall. Dive in and share with us, Enkosi.
Welcoming words. Thank you so much, Dr. Sobekwa. Then at the moment, now we are going to proceed with our program. We are going to call on Dr. Bayeni to introduce our first speaker for the day. Thank you.
Thank you very much. We are now going to be calling upon the first speaker for the day, who has been given a theme to talk on the future of the health workforce in the low-middle income countries, specifically focusing on challenges as well as opportunities that are available. She will be joining us online, and we are introducing to you Professor Rohina, who is a professor for global health at the University School of Population Health at the University of New South Wales, Sydney. She also holds an honorary appointment in the following universities, at the Sydney Medical School, University of Sydney, as well as Walter Sisulu University in South Africa. She completed her undergraduate training at Christian Medical College, Ludhiana in India, as well as a postgraduate training in public health from India. She went further to then pursue and obtained a PhD in medicine from the University of Sydney. Her research program aims to strengthen health workforce and health information system in order to deliver quality health care. As a senior technical advisor and OSHub lead for the Data for Health Innovation Initiative, she has the opportunity to contribute towards strengthening data for health in the Asia-Pacific region. Professor Rohina convene and teach the Global Health and Development course and give lectures for the MGH and MPH as well as BIPH program at the School of Population Health. She supervises Masters, PhD, as well as Dr. PH students at the University of South Wales. As a health system researcher, she leads and contributes towards several studies, including, if we may quote, Data for Health Initiative in Papua New Guinea, Solomon Islands, Philippines, India, whereby she also has looked at funding Bloomberg philanthropies. There's an assessment of diabetes prevention and control related interventions in South Asia that she has also contributed to, which was funded by the World Diabetes Foundation. She has gone further to participate in the review and revision of the Community Health Workers Training Program in Fiji, and as well as WHO steps in implementation in Fiji, funded by TFET. She's also been instrumental in the evaluating the impact investment case, as well as the scale up of health promoting schools in Fiji, as well as scaling up of competency of primary care workers to manage epilepsy by task sharing. She continues to also be instrumental in caring for the carers, which is a psychosocial supervision intervention to improve and the quality and sustainability of mental health services in humanitarian context, as well as the program where she also has been influential in the pragmatic randomized controlled clinical trial to support self-management for inhaler device technique and medication adherence among people with chronic obstructive pulmonary disease. Can we give a round of applause and welcome to present to us currently Professor Rohina Joshi. And over to you, ma'am.
Many tests. Can you hear me?
Yes. Yes, you may proceed. We can hear you loud and clear, and we can also see you.
Right.
Thank you.
Right. Thanks so much. Thanks for that very long introduction, which was just not needed, but thanks so much to I'm just super excited to be part of this auspicious day, and I want to convey my best wishes to colleagues at Walter Sisulu University for a day like today. So thank you so much for inviting me. You know what my topic is. So I'm going to start off the traditional custodians of the land on which my university, the University of New South Wales, stands. And I also want to extend that respect to the custodians of the land on which Walter Sisulu University stands. And I really hope that this engagement and this collaboration really bears fruit and respects the traditional custodians on whose legacy, whose knowledge that we share across the nations. So the talk, I've been asked to speak about the future of health workforce, and health workforce sits within the health system as we traditionally see it. So this slide here shows the 6 building blocks, the health system building blocks, in terms of service delivery, workforce, health information systems, medical products, financing, and then finally leadership and governance. And all of these together would ultimately, working together in harmony, would lead to improved health, would have a health system which is responsive to people's needs, would offer that social and financial protection, and have an improved efficiency in terms of delivering those services. But we can't imagine a health system without health workforce. And none of these would be possible without having a health worker. And normally we would think of a doctor, but a health worker is anyone from the doctor to the specialist or the surgeon and everybody in between. So to deliver health services optimally, health systems really need to take care of this workforce and need to train, retain, and sustain the health workforce. And so my talk today is going to be around these three pillars. I'll start off with some of the challenges. Some of them were already addressed in the first opening remarks. We often hear these because that number varies depending upon the type of study. But we know that it's in the order of millions. Within that, if you look at the acute health workforce shortages, they are in Africa, Asia, and Middle East. And of course, there's chronic underinvestment in education and training of health workers. And as we have seen with some of the research that comes out of your university, there is a mismatch between education and employment strategies. And of course, difficulty in deploying health workers to underserved areas. The opening remarks talked about the international migration, which exacerbates this shortfall, and underpinning this to understand how many doctors or nurses or pharmacists are available. The health information systems for the health workforce are weak. Now, these are some of the headlines that we see. Being an academic, I'm going to draw you to the evidence that is out there. And this slide it shows data from the Global Burden of Disease study. And what we see is the density of physicians per 10,000 population. And the colors range from if it's dark purple, I'm not sure how that is presenting on the screen right now, but it's dark blue or purple. That means it's a very healthy doctor to physician to population ratio. But if you look at the dark reds or browns, that's where there are very few doctors per 10,000 population. And again, I want you to from the perspective of where you are sitting, where you've come from, and also identify where those gaps are. Now, these are doctors. Let's look at nurses' lives. So it's, that story continues in terms of polls that Africa, South Asia, and Southeast Asia, there are huge challenges there. Now, I want to note that this is just looking at aggregate numbers at the national level. If we then disaggregate it by regional or just by rural, urban, again, look at where you are sitting and the areas that you are aware of. Look at the disparity amongst the availability of doctors and nurses, looking at rural and urban regions within countries. So this study then looked at how many health workers are needed for countries to have an effective universal health coverage index. And it's based on a lot of assumptions, but what they said was to reach 80 out of the 100 UHC effective coverage index, the world needs per 10,000 population, about 21 more physicians per 10,000 population, around 71 more nurses, 8 dentistry personnel, and 9 pharmacy-related personnel. So in 2019, if you looked at all of this, the total workforce, it fell short by 6.4 million doctors and about 31 million nurses and midwives. Now, please note the date. This is pre-pandemic. And we know what happened post-pandemic in terms of the health workforce. So there is a need for increased financing, training, employment, and retention strategies for health workers across the globe. So we know that is even more needed in low and middle income countries where there's need for innovation to attain this universal health coverage. Now, just looking at health workforce and looking internally at how some of the challenges faced by the health workforce, just summarized by four C's over here. There's changing demographics and chronic conditions. So if you just look at the population, many of the doctors, nurses, health workers are trained more in the acute care, maternal and child conditions, infectious diseases. But now we're looking at chronic conditions, and is our training linked to those sort of changing demographics? We know of the conflict worldwide, but there's also conflict within the workplace. And health workers they are at the front of all of these sort of conflicts that they need to endure. A relatively new aspect is around this culture of the rise of misinformation by social influencers using pseudoscience or actually no science. And then, of course, our health workers work within the complexity of health systems, as I showed you a few slides ago. So considering all of this and then adding COVID and the pandemic, what happened during the pandemic, it's just led to huge burnout amongst the workforce globally. And then it's further exacerbated in low and middle income countries. So enough about the challenges, let's look at the opportunities. And I really liked the opening remarks about creativity and how do we, like in India, there's a word called jugaad. How do we create these new innovative approaches which are part of our health system, but how do we strengthen them further to look towards the future? So as I said, I'm going to talk about workforce from the perspective of training, retaining, and sustaining the health workforce. So let's start off with the first block of training. We are all aware and know about those formal education pathways, but I think also thinking about the informal pathways for capacity building. So in terms of the formal training, there's medicine, dentistry, nursing. Alongside those traditional pathways, also around management and leadership, which is absolutely core to the health system. We can't expect doctors and nurses without training in leadership to suddenly lead these vast organizations or management of hospitals or health systems. Of course, again, we can't just focus on management and cure. We also have to think about that preventive aspect and look at public health, understand policy, health economics, epidemiology, advocacy, health promotion. But I think the future is going to be, how do different fields come together? How does medicine engage with law, with engineering, with digital health? How do we merge these different fields so that our workforce is trained and able and skilled to talk to each other, because we've got to think about that comprehensive environment in which people live. So upskilling and reskilling opportunities will absolutely be crucial for career progression. So we really need to rethink formal training as we do in today's day and age. So learning to use technology is something that will be absolutely essential to ensure optimal and efficient delivery of services. For this, health workforce would require lifelong learning for career progression. Upskilling for technology optimally will be a requirement. So what's happening right now is we are delivered technology and we are kind of supposed to learn ourselves. But there needs to be a way in which we are taught to upskill ourselves for career progression. Leadership, mentoring, sponsoring health workers to grow and transform their careers is even more important. Just because you are a medical doctor, you don't need to stay in your particular career, or if you're a nurse, how can you build your career so that you can go across the different the different aspects of health system. And so I think the boundaries between healthcare settings will also diminish as we transform from physician-patient care to more of team-based care. And so those informal training pathways would also include training for team-based care, job sharing, task sharing, or redistribution. I'll move on to staff retention, which is quite a topical, it's a topical issue, not just in South Africa, but in many regions. And again, it's not limited to low and middle income countries. Australia is facing issues with retention of staff as well. So in terms of retention, it's around understanding and implementing methods to motivate and retain staff, and also think of disruptive models of healthcare using evidence and technology. So in terms of retention of skilled health workers, I want to draw upon this study which was led by Professor Sikhumbuzo Mabunda, who looked at 4 different countries in Southern Africa and studied the effectiveness of return of service schemes for health workforce. And what he found was across the board, first of all, there was really poor health workforce data. He then found that 75% of the beneficiaries defaulted on the return of service scheme. And within that, he found out that beneficiaries who undertake internship training outside of their funding province, they have higher defaulter rates. Now that's within the country. There are issues around they're being trained and money is being spent, but they are not being embedded or retained within the public health system. The second paper was something that we did collaboratively, looking at health workforce immigration. And the recommendations that came out of that paper were that high-income countries must decrease their reliance on international medical graduates, especially from countries which have very critical or severe health worker shortage. Now, having said that, economic migration or migration is a human right, and people should be allowed to move wherever they want to in this world. But I guess one way of looking at it is also partnerships between countries that will enable workforce training and facilitate something called circular migration. So it's not just doctors, nurses, pharmacists, etc., moving from one country to another, but people from other countries also migrating back, enabling this knowledge exchange. And finally, the recommendations for governments in resource-poor settings were around improving planning and investing in healthcare teams with diverse skills. And I'll talk about the diversity of skill sets in a moment. So also thinking about the future of health workforce would involve having this care. And by that disruption, I mean having patient-centered care, the focus on prevention rather than purely treatment. Because as we would hear some of the health economists speaking today, that countries, the world cannot afford purely management. We really need to think about prevention as well. Thinking about community health systems and then embedding technology in healthcare. So my first point within disruptive models is around patient and family-centered care, which involves things like engagement. So not just looking at the liver or the kidney of this patient who is sitting in front of us, but understanding the entire being, that comprehensive aspect of the person, also understanding the social factors that impact that person, who has gone down to get, acquired disease. So that engagement with the family is really important. And for that, we need to think about systems outside of just that doctor-patient relationship. Communication is absolutely key. In many settings, if you are a healthcare professionals, can reflect upon the communications that occur within, within that doctor-patient chamber. It's usually a one-sided communication. Well, what I am suggesting is that we have this dialogue involving patients and their families, such that there is shared decision-making, considering what works for the patient and their family. Now, this does require a different level of training, because as doctors, our way of training does not involve, that traditional way does not involve these sort of factors outside the biomedical model. The next thing is around community health systems, which actually South Africa is really good at in terms of having community health workers, community health teams. But the idea is to take that community health system and really strengthen and transform it. So this includes things like community health workers, schools, peer groups, religious communities, bringing them together to look at health from a prevention through to palliation, the entire comprehensive approach. Within this, I want to focus a little bit about community health worker programs, noting that there is, one of my colleagues is going to speak specifically about it. But again, South Africa has this program primarily focused on infectious diseases and maternal and child care. And here's when I would like to discuss the opportunity of expanding or transforming that program to include chronic diseases, which is one of the leading causes of premature mortality in your country. So these are just some studies that were done by colleagues of ours across the world, which showcase that community health workers can do more than infectious diseases. They can deliver care for cancer, they can help screen for cancer, they can help with the control of hypertension, and they can also use digital technology to provide quality care in communities. And of course, my point over here is that this community health worker is not the only one. It is a team-based care, and she's then supported by the nurse, the doctor, and the larger primary healthcare team. Talking about digital health, this is a study from the Lancet Digital Health, which looked at various technologies from mobile health, telemedicine, EMRs, use of AI, etc., the impact of that in the performance of the health worker. And so what you see on this slide is a forest plot, which shows if it's on the right, if the red dot is on the right of that, of the x-axis, it's actually beneficial. So what this study showed was that using digital technology improves the accuracy and efficiency of the healthcare provider in the decision-making process. It reduces time and increases productivity. It makes data accessible quicker. It's much faster and reliable. It helps people acquire knowledge quite quickly. Of course, as you can see, there's some variables that are closer towards the zero, we don't have that evidence, that positive evidence yet. But overall, if we see, digital technology does have a positive impact on health or performance. I think as workers, we need to be trained in the use of digital technology. We need to be given digital technology as part of routine care, which will benefit the patients and the population at large. But having said that, while impact health workforce, we really need to make sure that we get it right. We are seeing that specialties such as potentially radiology shift some of its work to AI, and we already see that using radiology, one can pick up lung cancer, it can pick up a bunch of conditions, just run through X-rays through AI, and it can detect conditions which were previously undetected by radiologists. So there is a way in which one could collaborate with AI in a positive way, but that human touch is absolutely irreplaceable in the whole healthcare spectrum. And so I think one of the ways in which AI can be used positively was indicated around radiology and other aspects of providing decision care supports, but it also has a significant risk, especially in terms of disruption in workforce, the need for certain specializations. And that's why by health workers and having that balance, especially concerns around ethics, medical legal, impacts, as well as the other biases sometimes that AI will bring within the health field. So I guess thinking about the future of health workforce with digital technologies and artificial intelligence, we need to be prepared that we can use it well and not be scared of technology. So just building that digital IQ and raising that bar across the health workforce and not being fearful of it. So finally, to my last point around sustainability and sustaining the future health workforce, improving health workforce data is absolutely key. And just linking back to my previous slide, the study led by Professor Mamunda, which showed that basic data for health workers was not available in many countries. So not just national aggregated by age and sex is absolutely important for evidence-informed policy. National authorities should have strategic intelligence on health workforce, and the workforce projections should be made considering the population needs. So what I have over here is the data information wisdom pyramid, wherein you would use data, analyze it for information, use that information for knowledge, so that you can project into the future, have that wisdom to project in the future using that data, using that information, and having that knowledge. And finally, none of this would be possible if we don't have adequate funding. And realizing that without the right funding, we won't have the health workers, we won't have a motivated health workforce, and absolutely there is no health without health workers. So bringing it all together, just summarizing it, that the future health workforce is around training our health workers, not in those traditional forms that we know them as, but thinking about moving to the future, multidisciplinary care, having those informal pathways to work with others beyond healthcare as well. Retaining the workforce using disruptive models, but evidence-based disruptive models of care. And finally, sustaining them through sound policy, through good data and adequate funding. None of this would be possible without all of these evidence-based policies and visionary leadership. Going back to the basic thing blocks, we really need them to function well to support the health workforce for better population health. I'll end on this note, but I'm very clear your thoughts, your questions, and thank you so much for listening.
Thank you very much, Prof. And we would definitely have some thoughts. I would like to open the floor for some interactions, a couple of three hands or so, to interact with Prof's presentation before we then move over to the next one. I can share the hands to interact that currently sitting with our statistics in South Africa, making use of our health resource information system. and looking at the public employed staff, when it comes to our ratio for doctor-patient, if we use in a national landscape uninsured patients, using the census data of 2022, we are sitting at 4.484, which is 4.5 doctors per 10,000 population. And for the nurses, we are sitting at 13.1 in terms of the per 10,000 population. So that's based on our census 2022, minus the insured, as well as our personal or public employed doctors and nurses. Of course, it varies across provinces, and we did have a limitation when we were trying to get to that response, where at this stage we could not segregate in the provinces the insured population. So when we're calculating it per province, unfortunately, it's a bit skewed because we just used the census data without necessarily minusing the insured. Because our source at the time was the report from the medical schemes, which was at this stage only national data in terms of how many people are insured. But for Eastern Cape, for instance, we're currently sitting at 3.2 per 10,000 for doctors, if we just use the population versus those that are employed by the state. And for nurses, we are sitting at 14.5 at this stage. So we have been, it's very recent, colleagues. Unfortunately, we had to respond to a parliamentary question last week. So that's why it's recent that we know that we've worked on this issue of the ratios as a National Department of Health. And I was comfortable to share because it's something that we had to submit last week in terms of a response to a portfolio parliamentary question. And we used the sources that I've mentioned to get to that. Can we see a show of hands in terms of, yes, we see 1 there, 2 there, 3 up there.
Thank you for that presentation, Professor Ridley from Nelson Mandela University. I think you mentioned some approaches that you described as being disruptive, patient-centeredness, prevention, community health systems. But these are issues that we've been talking about for decades. So is it the fact that this is disruptive, or is it really a lack of advocacy or failure of advocacy to get it implemented? And perhaps some suggestions in terms of how do we effectively advocate for implementation of these approaches? Thank you.
Thank you. We'll have a second one. We've noted 3, 4. Okay. We'll take all 4 at once, Prof, and then you can respond. Thank you.
Okay. Thank you, Prof, for that enlightening talk today. I'm Tesha Pillay. I'm the president of the Professional Association of Clinical Associates in South Africa. I think it would be important for me to mention that within the South African healthcare system now, since 2008, we've been training mid-level healthcare professionals. And one of the avenues in which this came to light is because of the health resource issues that we were having within our country. WHO mandated that within lower and middle income countries that creating this cadre, this mid-level healthcare professionals that could aid in task shifting and task sharing would really help in the struggle that we're having. And then it's quite prominent within South Africa itself. We've been struggling to roll it out effectively within the public healthcare system. Since COVID, we've had a slower retention or employment of these mid-level healthcare professionals. And I think they do play a significant role And as part of the universities, as I can talk for Walter Sisulu, that when we recruit these students, we recruit them from these rural backgrounds with the knowledge of how rural areas is, in order to be well retained within the rural healthcare system, because that's where we typically find this retention problem.
In terms of the modeling, I'd be interested if you could perhaps reflect on some of the would normal.
If I may.
Sorry, I can't.
Yes, if I may represent him, he's asking for if you could comment on some of the variables that needs to be taken into account when we are doing projections on the ratios. Thank you. The last question is from the back.
Thank you, Prof. So, when you spoke about rethinking formal training for healthcare practitioners, in the same breath, you also mentioned considering measuring with other fields like engineering and technology, and in that you have also telemedicine, which measures from that. However, you also mentioned earlier that, because I believe that these advancements such as telemedicine means lesser of your physical personnel needed, but I stand to be corrected in that. However, that's a contradiction to the need that you mentioned of millions of healthcare workers needed for the UHC. How can we best reconcile that, the booming technology in healthcare in terms of telemedicine vis-a-vis the need to train more and more healthcare workers?
Thank you very much. We can hand over to you, Prof, to comment and respond to those inputs. Thank you.
Great, thanks for those questions. So the first one was around disruption. And thank you so much for asking that these models of care have been there since Alma Ata. What's the disruption over here? I hear you. I think what I was referring to, the disruption over there, was actually transforming those those community health systems. So what we have, and what we have in many countries, is community health workers who are chosen from the village, who work, do data collection, support maternal and child health and infectious diseases. Now, South Africa has done really well in upskilling community health workers to include conditions such as HIV. But still, issues like cardiovascular disease, various factors which start quite early in many of our countries, diabetes, cancer screening, kidney disease, a missed opportunity that we know we just focus on one part of the population. In fact, even with maternal and child health, we often miss gestational diabetes and not, those are all missed opportunities. In terms of that disruption, it's around how do we transform this health worker to somebody who's a volunteer, who was given some basic training and then left in the community without the accountability structures in place, without upskilling the community health worker themselves, without giving them enough staff to function effectively, and without giving them protocols or guidelines such that they can do their work efficiently within the community, but also link back to the health system through nurses, through doctors, and have that continuity of care for patients. So when I was speaking about disruption, I was talking about how do we bring that health system down to the community and link with the community through this health worker and also beyond this health worker. So that was the point around that. The second point around mid-level healthcare professionals and what's the future, considering that many mid-level health professionals who were employed are not being retained. I think the concept of having mid-level health professionals was fantastic, and it still is really useful within the context, not just in low and middle income countries. I would think even in a place like Australia now, which doesn't really have community health workers. So it's quite important. But I think it's about who are these people and what is their future in terms of the health system. Of course, they'll work for some time, get completely demotivated and move out of the health system. So I think it's more around what can the health system do to retain them? And we go back to those questions around retention of workforce, be it community health worker, mid-level health worker, or doctor, knowing that the doctor can easily move into a private health sector. So I guess some of the thoughts and some of the issues to discuss with policymakers is around thinking through the policies for the health worker. Are the jobs, the task sharing at the community level, is it defined? What do they, like, is there an opportunity for them to progress in their career? So I would look at more of those retention, motivation aspects of it in terms of how do we retain this workforce within the health system and see what their needs are, rather than just say that you're going to train them and you stay. But they would also need to have that career motivation of moving up or even serving their community but skilling up so that they can do a better job. The next point was around HRH projections and modeling, variables for modeling. So there are various ways of modeling, and I can just touch upon two topics. One is the model that I presented, used by the Global Burden of Disease. What they did was they used the Universal Health Coverage Index, and those are based on the SDGs about what needs to be attained by 2030. So things around prevention, things about management and cure, vaccination. They basically broke that down and had a UHC coverage index. I'm very happy to share that paper with you if you want to read further around it. But what their assumption was that for 80% of that UHC coverage, for countries to achieve that 80%, what proportion of those would be done by doctors, by nurses, by dentists, etc. So that they broke that down, and those were the assumptions driven into that model. The other HRH projection, which many would be familiar with in the room, is the WISEN model, Workforce Indicators for Staffing Needs, which looks at different aspects of needs from the population, sees how much time is required per procedure, and then looks at, okay, what's the workforce needed in order to do X, Y, and Z within a primary health setting, within a hospital, or within a country. Again, many studies done on WISEN. It's a fantastic model, but for that model, we need some good data to then make those projections. And again, happy to link in with you and share some of the WISEN work. In fact, Professor Mabunda has done a lot of work on WISEN, and he would be, he can share some of the work that we've done there. The final point was around telemedicine, and apologies, I might just have not got that question completely right. It was around so whether we would need enough workforce if we use digital technology in telemedicine. Did I get that right?
Yes, in actual fact, it was asking the balance between producing more and yet accommodating and introducing digital space. Thank you.
All right. Thank you so much for explaining that. So I think with the digital space, the idea over there was that one, so if we just think about somebody living in a rural region in Eastern Cape, for them to come down to a main city for a repeat visit for oncology or some chronic condition, think about them coming back and forth over and over. They will lose that day's wages, if they're daily wages. They would have a relative accompany them to the clinic. So there'll be two people whose time would be taken to visit that clinic, which actually could be a telephone consult with the same doctor. So in terms of the time required, it's actually time saving for the patient and their family. We still need that doctor or the nurse to have that consult with the patient. So in terms of the numbers, just with telemedicine, I don't think that will impact the workforce in terms of numbers. Now, when we think about AI, yes, so that does have one of the risks that we see is, would we be replaced by AI? Would university professors be replaced by AI that teaches masters or PhD students? And that's where one needs to also think about the element of human touch, the element of that empathy, that element of understanding the larger system. So the way I see it is that AI would enhance healthcare if we do it right. And that's why we need to test it out. We need to make sure we get it right, and that we don't just jump onto this latest technology, like bright and shiny technology, and use it or scale it up without making sure the checks are in place such that technology, which is evidence-based. Yes, it will have impact on the workforce, but I don't see it as a complete negative impact if we do it right. We just need to get that balance right and have the sufficient knowledge to kind of talk about what is it to get it right. Perhaps this unit can work on that aspect of human resources for health and AI. Thanks.
Thank you very much. Let's give a round of applause for the responses. And just to share in the insight that the experience we have, especially the example you made mention of oncology services, we do have patients that probably take out 3 days of their time when they have to come for services. So that's how bad it can get, and in terms of even now, the unintended consequences in terms of income loss, as well as time with the other family members. Sometimes they also leave other younger children at home. So there is that unintended consequence that also is an existing experience. It's not theoretical, it's not something that is not there, it's already existing in some of our areas. Thank you very much, and we really appreciate for the time that you've taken out, especially the insightful presentation and the engagements that you've shared with us. We've also noted that, of course, there's quite some lessons that we have to still ponder about, and the issues of the type of the mid-level workers that we're talking about, and what is their trajectory in terms of the future of the healthcare system, and where would they then be impactful. And of course, the issue of ensuring that even when we are enticed, as it is the space now, when it comes to digital health, as well as also in artificial intelligence, it's a question of understanding what our system needs at this stage and how we're going to balance that, and not just jump because we are being enticed to consider certain innovations. But of course, it still does not take away that when it comes to the health workspace and the health systems platform, we would always have a room for a physical or a human being in terms of the workforce that is needed, irrespective of whether we're moving with innovation or not. So thank you very much for those lessons that we have also noted. And we are now gonna quickly move over to the next presenter before we break for tea, which we're gonna call to the fore in the form of Dr. Thomas Gersten.
Thank you so much, Doc.
Now we are going to invite in the podium Dr. Thomas Gadsden. Doc is a research fellow at the George Institute of Global Health in Sydney, in Australia. His research focuses on health systems, health financing, and global health. He has worked in remote communities, international development, policymaking, and academic research. Dr. Thomas began his career as a youth worker in a remote Aboriginal community in Central Australia, working for the MT Theo program. After completing a master's in international public health, he interned at the WHO regional office in Manila for 3 months. In 2013, he was an Australian youth ambassador for development in Laos. From 2014 to 2016, he was a project officer at the WSU country officer for Laos, working on a project to merge the country's disparate health insurance schemes. During this time, he completed a postgraduate certificate in health economics. From 2016 to 2019, he completed the NSW Public Health Officer Training Program at the NSW Ministry of Health. From 2019 to 2023, he completed a PhD with the George Institute of Global Health, examining the design of incentives for community health workers in East Java, Indonesia during COVID. During this period, he also worked as a data manager for a local health district during the pandemic and as a tutor for master students in the subject Skills for Working in Global Health. As a research fellow with the George Institute, Dr. Thomas is currently leading a modeled analysis of the health and cost outcomes resulting from the differential rate of stroke diagnosis by paramedics between men and women in Australia, a cost-effectiveness analysis of a public health intervention in Southeast Asia, and contributing to the feasibility study to develop a local value set for health-related quality of life studies in South Africa. Let's call now Dr. Thomas to join us in the podium. Thank you, sir.
Hi everyone. I apologize that you had to hear my entire career. Someone's been reading my LinkedIn profile. I would have sent a shorter one if I knew that was going to happen. I'm just waiting to hear if I've changed the slides myself. So, first, thank you for the opportunity to present. It's a real privilege to be here with you today. I'm going to talk about the Smart Health program in Indonesia, which is a digital health intervention developed by the George Institute. I suppose this could be framed as a kind of case study looking at an intervention to support community health workers deliver quality care. It touches on what Rahina was presenting, but is a bit more of a deep dive into this specific program. Great, thank you. So, in terms of background, I won't spend too long on the challenges facing LMICs in terms of healthcare worker shortages and NCDs. This was well covered by Rohina. But just quickly, these graphs show the unequal burden of NCDs in low and middle income countries, the poorer access to care, to care and quality care, the poorer access to workforce and limited access to affordable medicines in LMICs. Thank you. And so, as we heard, community health workers have the potential to play a really important role in strengthening the delivery of care at the primary healthcare level on the front lines. And I like to show this photo when I'm talking about community health workers. I guess the WHO definition of a community health worker is reasonably arbitrary. There's several different definitions reflecting the many different types of community health workers globally. The WHO definition is that they typically have less than 2 years of training, that they're part of the community that they serve, so they live in the community that they serve, that they're not professionals, but they have received some limited training. Maybe I'll just say next slide.
Okay.
Yeah. Back, please. Yeah, great. So this reflects the many different types of community health worker programs that are out there. There's a huge variety. Some receive up to 2 years of training, some receive a few hours of training. And this varies depending on whether it's a government-supported program, and often we have very small community health worker programs as well, which are just supported by different NGOs to work on specific diseases. So there can be quite a lot of fragmentation even within one country. I'd like to show this photo because I think it exemplifies the WHO definition of community health workers. This was taken by me in a remote province in Laos, and it shows the woman in the yellow shirt who's a part of the Hmong community, which is an ethnic minority in the Southeast Asia region, convincing the other woman, who's also part of the Hmong community, to receive a polio vaccination from the 2 male healthcare workers there. So I think it really exemplifies the importance of community health workers in extending the formal healthcare system to often vulnerable populations and locations, and while also building trust in the system. Next slide, please. So to support community health workers, as Rohina mentioned, there's been huge growth in the use of digital health technologies. And this covers a huge range of health issues, from communicable to non-communicable, to mental health, to maternal and child health, and can be used, has been tested in a range of modalities, I suppose, most often in the form of mobile phones or in a tablet. As Rohina mentioned, there's many benefits that come from this technology. So it's typically low cost, and it can support community health workers to accurately diagnose and treat diseases. It also has the benefit of really supporting them to collect robust data that can be sent for monitoring purposes quickly. Next slide, please. So the program that I'm going to talk about today a bit more in depth is the Smart Health program. So Smart Health is the name of the model of care, and it's also the program that is based on a tablet as an application for community health workers to use. So the way it works is that the community health workers have this tablet with the application that they use to screen their the community members. It includes an inbuilt algorithm that, based on the data they collect, it determines their risk of cardiovascular disease. So that helps the community health worker decide whether they need to refer the patient to the primary healthcare centre for treatment. The application is also used at the primary healthcare centre by doctors and nurses in the form of what's known as a clinical decision support system, where essentially that supports them to decide which medication is appropriate to prescribe to the patient. The treatment plan put in by the doctors and nurses is then automatically shared with the community health worker so that they can monitor the patient in the community and ensuring treatment adherence. So it's a whole model of care that's connecting the community health worker with the primary healthcare system and integrating the service delivery for the patient. Next slide, please. So the intervention was quite well suited to Indonesia due to the kind of prevalence of cardiovascular disease, estimated to cause 1/3 of deaths in 2016, and with a high proportion of those patients not receiving preventive care. On the other hand, there was also a very strong community health worker program that already existed in Indonesia. Indonesia has one of the largest and longest running community health worker programs globally. So that workforce existed, which could be leveraged to deliver this program. Touching a little bit on the community health worker retention and motivation in Indonesia, it's quite a unique case, I think, in that the community health workers are village health volunteers. They receive a small stipend, but it's essentially a symbolic reward for contributing to their village. The program also really benefits from the cultural value that's attached from giving back to one's community. So there's a whole value, I suppose, that in Indonesia about supporting your community, and that kind of enhances the motivation to become a community health worker because it's seen as, it's recognized as bringing value. So, yeah, there were supportive conditions for this program. In collaboration with the district government, 8 villages were identified to deliver the intervention, with the outcome being the proportion using appropriate preventive medications at follow-up. And this was just tested in a pragmatic trial over 12 months. Thank you. So, as we can see from this slide, it had really positive results. It improved the quality of care, patient outcomes, and it was also found to be cost-effective. The results on the left of that table show that in the intervention villages, the proportion on appropriate treatment increased quite a lot. The proportion taking blood pressure medication also increased a lot, leading to reductions in blood pressure amongst the community members. So this was great, really positive findings, and the district government adopted the program to be scaled up across the district, which is a really great outcome. So it was they made a sizable financial commitment to taking on board implementation across the district to more than 390 villages and more than 1 million population. Thank you. But obviously, scaling up brings more challenges than just testing the intervention in 8 villages. So to do this carefully, a whole framework was developed around ensuring that implementation was contextually based so that the program could be adapted to local conditions before expanding more and more to different villages. So the model for this was based on something called a Plan, Do, Study, Act, a PDSA cycle, which is a model of care, a framework typically used in to improve quality of care. And there were 3 of these cycles, and you can see at the bottom the weeks, so it ran over 10 weeks each cycle. And the purpose of this is to kind of iteratively implement the intervention while taking on board potential barriers, adapting the intervention based on change strategies which are developed for a team, testing those strategies on a small scale, and then again monitoring implementation and continuing the cycle. And that's represented by the graph here. So we have the implementation in the bigger box with data collection ongoing, quantitative and qualitative, implementation barriers identified, and then change strategies identified through working groups, including key stakeholders, and then used to inform the next round of implementation. so that it can really be tested and adapted to the local context on a small scale before going to a bigger scale. Thank you. So, unfortunately, this coincided with the COVID-19 pandemic, so there were major disruptions to implementation. This slide shows some of the barriers that were identified and the change strategies used to try to address them. COVID-19 obviously being a big one, really disrupted delivery of care. One of the adaptations was to centralize screening so that people come to a centralized location rather than doing door-to-door screening. Several other smaller barriers identified, such as refresher training required for the community health workers, additional equipment needed. What else did we have here? New tablets required, a bit of targeted screening required, so targeting males where it was found to have low rates of participation. One of the key barriers that we found, though, was challenges with the application itself. So there were very slow loading times and malfunctions, which I don't think were as problematic in the trial, but became a real issue in the test of scale up in 10 villages at the start, as well as integrating the data collected with the electronic health system at the primary healthcare system level. So making sure that the data collected by community health workers was received and integrated into the primary healthcare level data system, which wasn't achieved, so it was a big barrier for implementation. Next slide, please. So I just show this here. This is the number of community members screened in each of the 3 cycles by village, 10 villages at the start of this test of scale up, so a small scale test. And we can see that the implementation ran as planned in the first cycle. Second cycle was really hit hard by COVID with a lot of lockdowns in villages, so only a couple managed to do some screening. And then cycle 3 really got away from the 10-week implementation. It was extended to more than a year to try and work out those issues with the application, the malfunctions, as well as integrating the data with the primary healthcare system electronic information system. Yep. Next slide, please. So, evaluation of the scale-up is continuing. It's expanding beyond those 10 original tested scale-up villages. But it's taught some really good lessons about the challenges of taking something that was implemented on a reasonably small scale in a pragmatic fashion, but expanding that to adapt to local context comes with many more challenges. And these are some of the lessons that the integration with existing electronic information is absolutely critical, and it's been fundamental to have a dedicated IT team to support that process. But it's also been really positive to see that there has been a high level of government buy-in throughout the test of scale up. So, and we could say that's reflected by the amount of change strategies that were tested to refine implementation over the period. And that's come with financial commitment as well. So I've talked just about the Smart Health program in Indonesia, but it has been tested in other countries and is undergoing testing or moves to implement it in other countries, working on a range of different health issues. So some of these other countries here are India, China, Thailand, Sri Lanka, covering different issues from cardiovascular risk assessment in Indonesia to diabetes, mental health, and HIV. And I'll just finish on this slide. It's some of the key messages that have emerged from the broader program of work about the potential of Smart Health to support community health workers deliver quality of care at the front lines. Thank you very much.
Thank you so much to Claire
Thank you so much to have an audience who so much participated. Whenever somebody is done talking, there's a round big of applause, not being asking me to do it, but you just automatically do that. Thank you so much for that. Now, Dr. Thomas, while he was presenting here, he was presenting a study which was done in Indonesia. And the study was about use of screening and decision support app to support village health workers, village health volunteers. Now he has stated very well that the app has been tested in many countries and it is working. And the app, I think, also can work for us here in South Africa. If it is going to be implemented, so that the screening of the clients is done in the communities where the doctors and the nurses are working, for example, in the primary care facilities. Then if the screening is done there in time, the clients will be diagnosed in time and be assisted and be helped in time before the complications can be there. Then on that note, if there's any person with questions for Dr. Thomas, I'm showing to the audience. What is the young man who will assist us with the roving mic? Okay. Any questions?
Can you please see, show of hands? Oh, there's one at the front, there's one at the back, there's one. All right, thank you.
No, thank you, Chair. Percy Mashat. Mine is not a question, but a comment. Maybe the colleagues here in the country can actually say how we overcome it. I don't think the program software would be a challenge. The challenge is the competing software programs we have in the country. Each one coming with this, each one coming with that, and the various gadgets. I'm not sure whether you've had that challenge, and how you overcame that. Because we do have, but the problem is that they're not using the same baseline, for instance. So if you could just comment on that. Thank you.
Yes, that's a great point. I didn't touch on it when I was just briefly mentioning digital health with community health workers, but it has, it's exploded the amount of applications that there are for community health workers to work on this problem, on that problem, and it could be detrimental to the point that it's overburdening the community health workers to deliver their main role. So I know in Indonesia they have this problem. There's over 400 apps, I think, have been developed just by different government alone. And I know they have developed or established a team to work on synthesizing them into a smaller number that's more manageable, to have some coordination, some high-level coordination around this issue. In terms of whether it was an issue in this case with the smart health application in Indonesia, I know there were ongoing discussions around other applications that existed and kind of a little bit of a competitive environment in terms of which one is going to win out. The one, in this case, we had the issues that I mentioned with the application about loading and malfunction and integration with the existing electronic information system, and that spurred on the development of a government app broadly based on smart health to do the same thing to complement this one. So, yes.
Thank you, Doc, for the presentation. I was actually impressed with the presentation of the Smart Health program because you mentioned that in the program you guys pick out people from the area that you are taking the Smart Health digital marketing in. So it would be helpful here in South Africa because if we could go to clinics and actually take people from the community, it would really help because some of us as youth or young people are actually unemployed. So getting to know and being innovative in technology and learning this digital marketing would really be helpful to our youth. Thank you.
No, thanks, Doc. I'm the KKM. My question was partially covered by Dr. Malat when he asked more on the current existing gadgets in terms of conflicting of gadgets. But mine is more on the data integrity, which of course we touch base on the issue of the relevance and the significance of the very same app. I'm more interested to know which data reconciliation tool do you actually focus on when you were hitting the ground in terms of collecting data, the very same stuff that we're embarking on. Thank you very much.
Sorry, I'm not sure I understood the question. Focus on collecting.
Remember, in terms of the data integrity, our focus is more on timeless, correctness, and then its commitment. So I wanted to know if ever there was a specific data reconciliation tool that you actually did in terms of comprehensively coming up with the output.
I'm not quite sure, to be honest. You've stumped me a bit on that one. No, I might have to get back to you on that one, sorry. Apologies, we can talk about that. Yeah, sure.
Any other questions, colleagues? I can see no hands. Let's again give Dr. Palmer a round of applause. Thanks so much. Now I think we have reached at the time where we must have our tea, and our tea is served behind us. And our tea will be only 15 minutes from now. Then when we come back, we'll continue our program. Can we please grab our tea and have it? Thank you so much.
Thank you very much. And we are told those that might have gone through the other side home in the morning, they can go there to verify their details as we go for tea. I got difference. Something. Thank you very much, colleagues. We will see you in 15 minutes time. Thank you.